Hi, it's Dr. Centeno, and thanks for joining us this morning. Got some interesting stuff to go over. As usual, I'll spend about 10 minutes or so going over a particular topic, and then we'll use the rest of the time. We got about an hour this morning to go over extensive Q&A. So if you've got a question, if you're watching on YouTube or Facebook, just go ahead and put your question in the comments, and I'll see it here. I'll answer the questions in the order I see them, which is going to be the order in which they're posted. So if you really want to make sure that I get to your question, then obviously get that in early. Topic today is going to be ePICL and outcomes. I do this about every 6 months or so. I'll do sort of a rundown on what's going on with ePICL outcomes. More frequently now, about once every 2 weeks or so to once a month, I'll put the most recent outcomes in the PICL Reddit sub. And then this goes a little bit deeper into ePICL outcomes than that, in that I've looked at lots of different groups trying to gain some insight from what's there. And then, as many of you know, we're completing a peer-reviewed publication. But this last couple of months, I've been trying to make sure that we get to hear from everybody who had the procedure. So I've been beating the bushes, if you will, out there trying to contact old patients, trying to make sure that they get their outcome questionnaires filled in. Whether or not they did well, didn't do well, doesn't really make a difference to me, because ultimately that all goes into the paper. So again, this morning, we're going to go into ePICL outcomes to treat craniocervical instability, also about 10 minutes on that. And then we'll get into extensive Q&A. If you're on Facebook or YouTube, just go ahead and do me a favor and put your questions into the comments. I'll get those here, and then I'll answer those in the order I see them, which is going to be the order in which they're posted. So if you want to make sure I get to your question, then get those questions in early in the comments. So let's get into the ePICL discussion and all of that good stuff here. So going to get into ePICL. So what does this data really apply to? The data that we're going to be going over today is the as seen case series. So what that means is that this is as patients are seen in the clinic. I will record their SANE score, singular assessment numeric evaluation, and I will take notes, as well as Dr. Schultz is now doing this and Dr. Pitts, on what's improving, what kind of symptoms they have, if they've got other comorbidities, things like hypermobility, etc. And if there's something interesting about their function, that's usually recorded, like this person went from bedbound to whatever. Now, that's a more informal data collection apparatus than the registry that we run through Regenix. And in the registry, we have lots of different more formal functional questionnaires, things like the headache inventory, SF36, neck disability index, numeric pain score, as well as a SANE. Obviously, that takes time for patients to fill out. And believe me, if you've been treated in my office, please fill that stuff out, because that's what goes into peer-reviewed publications. But if we're looking at quick and dirty, what's working, what's not working, how well is this working, is there a subgroup that seems to be under or overperforming, then what we're talking about today is a nice way to go. What this data today doesn't apply to is what I call fake and bake PICLs in Europe. So it doesn't apply to whatever the heck is going on in Hungary, which is not what I consider a PICL. It doesn't apply to what's happening elsewhere in Europe, which again, I don't consider PICLs. Neither of those providers were ever educated by me on how to perform a PICL, so I don't know what it is they're doing, but suffice it to say that what we're talking about today doesn't apply to those procedures. So this is the dashboard that I publish. Now it's about every 2 weeks. It'll probably go to once a month. And this is that as seen case series, right? So what happens here is the patient comes in. Now we see patients for their first PICLs and then second, third, subsequent, etc. So as they come in for the second PICL, we're recording a percentage improvement, what's called a single assessment numeric evaluation or SANE score. And then we're also taking some notes about the patient. So this is now data from 129 patients that have been treated. And the current percentage improvement is about 48% in 1.9, you could say 2 treatments. So just under 50%, let's say, in 2 treatments, and we're going to round all of that up. And the percent improvement per PICL is about 25%. And then we break the response per procedure into various groups. We've got the mega responder group, which is someone who just knocked the ball out of the park. They got more than 50% improvement from their first procedure. And then people break into then 3 other categories, what I call robust incremental improvement, which is about 38% of the patients. The mega responders, 24%, as you can see there. The incremental responders are getting between 15 and 25 per PICL. And then the slow responders under 15% per PICL. And then off to the right there, you see total improvement. And it's also now important to know that there are 26 Schultz patients on this dashboard and 4 PITS patients. And as time goes on over the next couple of months, you're going to see those numbers grow, meaning that previously this was mostly my patients because I was the only person really doing this. And then at the request of other patients out there on the Reddit sub, they started to say, hey, we'd like to see some information from Dr. Pitz's patients and Dr. Schultz's patients. So I've asked them to start doing this. And there were some growing pains in that. They didn't really know what I was doing, what I wanted, how I was doing this, because I was the only one doing it. But I think they're now both onboarded there and understand what they need to record. So these are the CCI types that the patient's seen. The vast majority are type 2B, which is going to be that side-to-side C1, C2 instability. And then we have various other types. 2A, which is going to be when the atlantodental interspace opens up, more of a transverse ligament thing at 16%. The 3As are going to be where 2 moves forward on 3 in flexion. The 3Bs are going to be when 2 moves backwards on 3 in extension. The 1As are going to be that low clavoaxial angle type CCI. And then the 1Cs, skull sliding type CCI. So it gives you some idea of the CCI types that the patient's seen. Now realize this isn't a perfect graphic. And the reason why it's not a perfect graphic is that some of these patients don't have the resources to be able to get multiple imaging modalities. So they might be able to afford to get an upright MRI and then they get qualified as CCI, but they can't afford to get a DMX or vice versa. So as you might imagine, if in a perfect world where we could order every possible test on every single patient and resources didn't matter, we would have a better idea of what these look like. But for instance, if they got a DMX, then 2A can be seen on DMX, 2B, 3A, 3B, whereas that's not as good at looking at 1A and 1C, and that would be better with an upright MRI. So realize that some of what's on here is dependent on the fact that patients do have limited resources, most patients, so they can only get one type of imaging or another. And then these are the different symptoms that are there that we recorded as improving. Now, this doesn't tell you what percentage of patients, for example, with headaches improved. It only tells you that about 69% of the patients that we had on this as seen case series reported improved headaches. 67% improved neck pain, 60% improved dizziness. You can see there brain fog, fatigue. And the reason I show this is I often get these questions from patients. Well, I have X, Y, and Z. So I have POTS, for instance. Do you have patients with POTS that improve? Yes, 22% of our patients report improvement in POTS. Now, that doesn't mean that only 1 in 5 with POTS are improving. Because the vast majority of our patients, only about 1 in 4 have POTS. So it just means that that's what has been reported as improving. So that's why I show this list. And so this was an interesting one. This is some of the analysis I recently did on that data set, and that is trying to look at autonomic type symptoms. And for me, autonomic type symptoms are going to be POTS, tachycardia, GI symptoms, other cardiac things, those sorts of problems. And about 1 in 9 of our patients had clearly autonomic symptoms. And their overall SANE improvement is very similar to the rest of the cohort. So I get asked this question a lot, right? If I have autonomic symptoms, am I a good fit for this? Does it make me a bad fit for this? And the answer appears to be no. It doesn't make you a bad fit for this. You are a good fit for this kind of procedure. So at the end of the day, if you have autonomic symptoms, that doesn't seem to preclude you from this type of treatment. Now, this is actually looking at top symptoms that improved most often. And again, not a perfect graphic, unlike the data that we collect for research purposes, where every single one of these symptoms is categorized, and then we're looking at improvement. This is just based on the notes that are on the as seen case series spreadsheet. But it does give you an idea here again, when neck symptoms are reported, 91% of the time, they're improving. When headache symptoms are reported, 88% of the time, they're improving. Dizziness, lightheadedness, et cetera, et cetera. But realize that this is relatively low N here, meaning number, simply because at the end of the day, the doctor had to state patient had neck symptoms and those are improving. If the doctor didn't state it that way, this wouldn't pick it up. This is a big one I get asked a lot, hypermobility EDS versus non-hypermobility. And I have looked at this one now ad nauseum. I apologize, everyone. I've got Alaskan Malamutes who sometimes go a little crazy when they hear an ambulance out there. So they are thinking that ambulance is a dog and they're howling. But anyway, this one I get asked a lot, right? Hypermobility versus non-hypermobility. We've looked at this now 3 or 4 separate times with 3 or 4 separate analyses. I've looked at it in the larger research database. I've looked at it in our own as seen case series. And at the end of the day, there isn't really a difference between how hypermobile patients respond to ePICL and non-hypermobile patients. They respond about the same. So that's an interesting one. And again, one that I get asked all the time. Now, interesting, if you break patients into these symptom clusters, autonomic, we've talked about autonomics. Mechanical, that's going to be the classic. I got into a car crash. I've got headaches, neck pain, dizziness. And then neurocognitive, that's going to be more brain fog, concussion-like symptoms. And we look at the fact that all of these patients have about a 31% per PICL procedure improvement. The autonomics actually do a little better. But again, this is plus or minus 31%. So for the autonomics, that's going to be approximately a 38% improvement per treatment. For the mechanicals, that's going to be about a 32% improvement. And for the neurocognitives, that's going to be about a 29% improvement. Excuse me. So at the end of the day, a lot of these patients are improving, but it maybe suggests that as we get more data, it could be that certain clusters of symptoms do slightly better than certain other types of clusters. But certainly the autonomic patients are not doing worse. And this is a heat map of that same, all those same symptoms. So when it comes to GI, autonomic, paresthesia, these are actually improving quite nicely compared to others. And then this is a big one I get asked as well, which is low functioning. And low functioning I defined here as bedbound, housebound. So these are some of the lowest functioning patients. And in fact, they're some of our strongest responders, as you can see. Now, why is that? I think there's a little bit of what medical researchers call here reversion to the mean. And that is, at the end of the day, if you've got a lot of gains to make and a procedure is going to be effective for what it is you've got, then that person is going to see more improvement than someone who's a little bit closer to the mean. And once you get towards the mean patient, those improvements tend to be less because they've got less to improve. So I think that's probably what we're seeing here. We don't have a big N on the bedbound patients as well, meaning a big number. But this is not surprising to me because this fits with what I see day to day. So I do want to mention the peer-reviewed paper. We're just finishing up what I call shaking the bushes, and that is going out to patients who did not respond to questionnaires. Please, 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 if I have contacted you via email, or if you keep getting these emails to respond to a questionnaire, or if you've never even seen an email for a questionnaire, please check your junk folder and try to find these emails and respond to these. If you could do that today or talk to others on social media about doing that today, that will help us get this paper out, because I'm trying as best I can to get as much response data in this paper before we pull the trigger on publishing it. And that just makes the most sense, right? We want to see how the maximum number of people respond to this procedure. We want to see the good, the okay, and the not good. We want to see it all. So please, 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 if you had a procedure done, check your junk mail, your spam folder to see if you got an email from Regenexx or the Regenexx registry. And please click on that link, fill out those questionnaires. And if you got an email from me personally saying, hey, how you're doing, you haven't responded, please respond, because I can get you a new link. And then if you have responded and Aaron sent you a link, but you just haven't gotten around to filling it out, please fill it out. So in summary, we've got promising data that ePICL is helping patients avoid fusion. And that's still about 7 in 10 patients. I think a little bit more these days, but we'll say 7 in 10 to keep it reasonable, that are doing well with this kind of procedure. Okay, well, let me get rid of the slides here, and let's go to trying to answer some questions. How can I get into Facebook craniocervical instability? Regenexx PICL, I've been trying for many months. You know, I don't run that. We're not involved in that at all, really on purpose. I don't do that primarily because I want a safe space for patients to go where I'm not involved at all. My staff is not involved at all. So I really have no control over that. That's run by patients only. So I don't know why that's happening, but I don't also have any control over that. What I do have control over is the Reddit sub. That's Reddit RPICL. And that one, obviously, if you have a hard time getting into or there's some other problem there, I can troubleshoot that for you. How many different autologous blood products do you use for what purposes, like platelet lysate, for muscle tears? I'm sure you figured out Alpha Recipe and Regen Med. Yeah, so almost everyone that does Regen Med is what I call a one-trick pony, right? They can produce some PRP, maybe they can produce some bone marrow concentrate with a little kit, but they don't have a lab doing this. Why don't they have a lab? Like we have a lab. It's expensive. Our lab cost $1 million to build. It costs hundreds of thousands of dollars a year to maintain. And that's versus a little kit where they give you the centrifuge and then you pay on a per click basis for each kit, maybe a couple $100. Now, why do we use a lab? We use a lab because we can make all of those different things. We can make low dose PRP, high dose PRP. We can make leukocyte rich PRP, leukocyte poor PRP. We can make platelet plasma, PPP. We can make platelet lysates of various concentrations. We can make a 1 fraction stem cell bone marrow concentrate, a 2 fraction stem cell bone marrow concentrate. And you just can't do that with kits. So obviously, if you're seeing a provider that uses kits, that provider is limited as to what they can offer you. So yes, for instance, PPP has been shown to be better for muscle tears. So in muscle, we'd be using PPP. Around nerves, we've seen platelet lysate be more anti-inflammatory and pro-nerve regenerative. So that's what we're using around nerves. For injecting a disc, for example, leukocyte-rich high-dose PRP would be much better than leukocyte-poor medium-dose PRP. Again, if you're using a kit, you can't do that stuff. But since we've got $1 million lab, we can do all of that and more. I have constant tinnitus, which I know can be from CCI-TMJ. Mine will get more pronounced with jaw movement, turning head, exertion. Only thing I find on this is that TMJ related. So tinnitus that is changed by head, neck, jaw position is usually related to craniocervical instability in my clinical experience, less likely to be related to TMJ, although realize that the structures that can be impinged on and cause tinnitus, like the internal jugular vein, can be changed or morphed by jaw and anterior strap musculature position in CCI patients. So again, usually CCI here, and if you've got tinnitus that's morphed by head, neck position, jaw position, etc., then that usually means that you're dealing with tinnitus due to craniocervical instability. There could be other causes as well. Do you usually prescribe painkillers after a PICL at your clinic? If so, what kind? We do. So the most common one we use is Percocet. Some patients don't like Percocet, in which case they're getting Dilaudid. Some patients don't want any narcotics, in which case we'll give a non-narcotic, something like Ultram. And some people don't want any of that, in which case we can give alternates as well. Elving, is it common to have pain in the trapezius? Let me start over there again. Elving, is it common to have pain in the trapezius and levator if you have instability at C1, C2, especially if you're in upright position? You know, it is common to have pain in the trap and levator with instability at C1, C2. But Elving, there's lots of other things with regard to the neck that can cause pain and tightness in the upper trap and levator. So not just CCI, but having said that, C1, C2 instability patients have a lot of tightness in those muscles. Good afternoon. I think it's still morning here, Mountain Time, but I think it's afternoon Eastern Time. Dear doctor, I've noticed that since getting CCI, I need to stack more pillows in order to breathe fully. If I put only one, I'm getting a choking sensation. What are the physical mechanisms behind this? One of the things we see in CCI patients is that the instability can lead to positional problems in the airway. And in the same way, you've got to realize that those upper cervical bones are only separated by 1 centimeter or less of soft tissue from not only the airway, but the swallowing tube, if you will, or the esophagus. So it makes sense that if you've got CCI that could affect swallowing, that could affect breathing, simply because changes in shape of the upper cervical spine can impact the airway. So that's probably what you're dealing with, or better said, that's what patients who have CCI, who have problems with positional airway issues are dealing with. Vero, hello, Dr. C. Why would translation measurements substantially differ between DMX and flexion extension x-rays? Yeah, so it's a very good question. DMX is a different animal, and it's a different animal because you get to move, stop, and then reverse direction. That's a different movement than looking down and holding it and taking a picture, and then being asked to look up and hold it and take a picture. So it's that reversal of motion from flexion to extension that really tends to make DMX shine in looking for instability. Now, you can also look for instability in flexion extension x-rays, but in my opinion, a little less sensitive. Now, also, what can make the difference there is if the patient got the same kind of motion in flexion in both the flexion extension x-ray and DMX, and or extension, because if you don't get maximum flexion and maximum extension, you can miss instability, and that's called a false negative test, right? The problem is really there, but you didn't move enough to show it. Hi, Dr. Centeno. I've had 12 rounds of high volume cervical prolotherapy with many syringes each time. Could this prior tolerance-based approach reduce the effectiveness of the smaller, precise PICL? Well, this brings up a couple different issues. Number one is, please don't get a dozen PRP injections. There's really no rationale at all for getting more than 3 or 4 PRP injections. If 3 or 4 PRP injections aren't really moving the needle, then it's time to move on to something else. And I can almost even tell you which clinic did this, because I don't know of another clinic around the United States that will push it this far, meaning that most prolotherapists will do a couple PRP or prolo sessions, and if it's not helping, they're going to move you on to something else. But we do have clinics out there that will continue to push you to do more and more and more. So there really isn't any rationale to do a dozen prolo visits. Please stop after 3 or 4 if you're not getting fairly dramatic improvements with each one. Now, having said that, could that cause problems for a PICL procedure going forward? It could. One of the problems I tend to see with patients who have had this amount of prolotherapy is that they're pretty scarred down and they've got very poor range of motion. So that's one thing. But if it hasn't really impacted range of motion, it's probably not going to be a net negative. But again, just to review, there really isn't a rationale for getting more than 3 or 4 prolo visits. If 3 or 4 visits aren't really knocking the ball out of the park, then it's time to move on to something else. And the reason why I say that is I see patients out there who get this stuff. They spend an immense amount of money getting this stuff, and then they're kind of tapped out financially. So they can't do anything else when this doesn't work. Hey, do me a favor, give me a like, share, subscribe wherever you are. That's a good way to pay it forward in the CCI community, because at the end of the day, realize that if you're a patient with CCI and you don't have access to good, solid information like this, you're going to be lost. And I'm sure each one of you were lost at some point until you found access to good information. And without those likes, shares, subscribes, etc., we can't get the algorithms to go ahead and put this in front of those other CCI patients. So if you want to pay it forward to the CCI community, you do that by liking this, sharing, subscribe, so that other CCI patients can see content like this. Are you collecting data? Maybe this meant to say PICL. We are, yes. I think that's what that one says. Maybe there's something else there. Let me know. Submitted advanced by Sherry Scott. Are aspirins or Tylenol safer for severe headaches for people with CCI? I don't think either one is unsafe. If we're looking at the use of non-steroidal anti-inflammatory drugs, then there's some information that's been published that would suggest that any drug like that interferes with the normal inflammatory healing response is going to cause more chronic pain in the long run. So if you had to look at it along that axis, you would say Tylenol might be a bit better. But again, you're probably going to see the same thing. And in both of those, you're going to see patients who become addicted to those not addicted in the classical sense, meaning if they stop them, they're not going to go into delirium tremens or withdrawal, but they can't function in life without taking those drugs every day. And so when we get to a restorative regenerative medicine procedure, it becomes very hard to treat those patients because they can't function without it. And we have to take them off that stuff during the procedure. And they're like, wow, my pain went up. Why did it go up? Well, it went up because you were addicted to taking Tylenol. You were addicted to taking non-steroidal anti-inflammatory drugs like naproxen, like ibuprofen, like Motrin. You couldn't function without, so we'll then have to restart those patients on those drugs just to get apples to apples comparison as to where they are. So be very careful there. Those drugs are not to be used and abused to function. They're to be used on a very occasional basis to help with pain. Alex, I read that you said PRP and facets works within 1 to 2 weeks, max 1 month. Does it mean dizziness is coming from facets? It should be gone at max 1 month. Confused how that total time is 3 or 4 months. Total time for a PICL procedure or ePICL procedure is 3 or 4 months, Alex. I think you're confusing that with how quickly patients respond to PRP in facets. The PRP response in facets would be more like what you have described, which is kind of a couple of weeks. Now, having said that, if the dizziness is being caused at C23 or C12, and there's still instability, which might not be helped more like until we get to the 3 or 4 month mark with bone marrow concentrate, then you could very well still see dizziness symptoms despite the fact that the PRP has effectively treated the joint. You've still got instability pissing that joint off. So realize that we're kind of mixing two different things there, the response to ePICL versus the response to PRP and facets. And then if there's still instability, you're still going to have problems until that instability is treated. Taylor Hingley, I want to understand how CCI is affecting me while I sleep. Not sure what you mean by that question. CCI can cause obstructive sleep apnea, mechanical sleep apnea. So that's one way it can impact sleep. Many CCI patients also can't get comfortable. And in fact, they can get symptoms, especially at C1, C2, for example, when they're lying on their side, because their head goes that way and their spine stays in the same position. And so that can really affect sleep quality. Casein and regen for peripheral joints, how often do you inject extra-articular ligaments like collateral legs or associated tendon attachments? Comprehensive approach would say most extra-articular targets are needed. Yeah, so that's very typical for the way we've always done this and the way we've trained now hundreds and even thousands of physicians to do it. And that is you treat the joint intra-articular, but you also often need to treat loose ligaments if they're present, pissed off tendons if they're present, etc. So that would be the way we treat the joint. You could say taking a whole joint approach rather than just treating the inside of the joint. Having said that, casein, the more recent research would show that if you've got any kind of arthritis in that joint, you also need to be treating the bone, which is intraosseous. So it's kind of even gone above the level that you're describing in the peer-reviewed literature and what's already published and what I've got insight to about what's about to be published. I can tell you that what's about to be published is going to further refine that story that injecting the bone is probably the single most important thing that's happening there. Do you ever see patients who have steady improvements continuing after PICLs for a very long time, incremental but meaningful enough to keep treating with PICL? We do have a few patients like that. Not a lot. I would say they're the edge cases. What I mean by edge cases is they might be in that 5% of our patient category. But yes, we do have patients like that. And it's always a hard decision, right? Do we continue doing this or do we move on to a fusion? And I always draw the line at if I can definitely tell and talk to the patient, and the patient can relay that they clearly have made a substantial functional gain, then we'll generally continue. Having said that, each time we're having that conversation, hey, you could do a fusion here. So I just want to make sure you understand that. Courtney, can you explain the 2B and 3B CCI example? What movement indicated each types of those? Sure. So 2B is C1, C2, side to side excessive motion, like you would see at an open mouth lateral bending DMX. A 3B is going to be in extension when 2 goes backwards on 3. So the first kind of CCI is going to be due to laxity in the alar accessory ligaments, which you have to target. So that would be that ePICL procedure. And the second kind we just talked about, so that's the 2B. The 3B, you would need to treat the anterior longitudinal ligament. You could do that through the front this way, although it's hard to do at 2-3 because it's kind of high. Or more conveniently, you could do it as part of a PICL procedure and get that 2-3 ALL. Q just watch. Does pure PRP have worse results in ligament regeneration compared to protein-rich, platelet-rich plasma? What is the difference? So I think you're kind of mixing up a bunch of concepts there. I would say that you're kind of mixing up marketing concepts with actual science and medical data. So pure PRP is just a brand of leukocyte poor PRP. There's nothing special about it. It just means that it's white blood cell and red blood cell poor. So it's an amber kind of PRP. Now, the whole protein-rich, platelet-rich plasma thing is a little bit of bullshit. What I mean by a little bit of bullshit is they're taking PRP of some type. I don't know what type. It could be leukocyte-rich. It could be leukocyte-poor. And then they are dehydrating the plasma with basically a stock dehydrator, no different than the stuff they use in baby diapers that pulls water into it. And then they're claiming that's protein-rich plasma, and they're adding that to platelet-rich plasma. That's a little bit of marketing gimmick. No one has a clue whether or not any of that is any better than just doing PRP. Let's stick with what we do know. What we do know, what we do have excellent data on, or good solid data that's developing, is that if you are middle-aged or older, that high-dose PRP works better than low-dose PRP. So you should be more concerned about what dose they're getting to if you're in that age range, and equally concerned about exactly where that PRP is going, because there's a vast difference between the ability to get it where it's supposed to go and not. And that's really hard to figure out. So those are the two things I'd be more concerned about than sort of clinic marketing, internal marketing BS, which doesn't really make scientific sense. It's just so that one doctor can try to claim that they're using something else, but we don't have any data that shows that that something else is any better or worse than what's already being used. Nathan, could CCI cause scoliosis in the thoracic spine? And would the thoracic spine need to be injected too if I have both? It could, or it could go the other way. So in CCI, you're going to have proprioceptive issues. That is trying to determine which end is up because of the bad position sense coming in from the upper cervical spine. So if you've got this and you think that's straight up and down, your body needs to write your visual field. So it's going to write your visual field by doing this, which is going to put a bend in your thoracic spine. Having said that, you could have had thoracic scoliosis, which then causes rotation at C1, C2, and you get upper cervical symptoms, maybe not CCI, but you're getting upper cervical symptoms because of that thoracic issue. And then the answer, Nathan, is that we frequently treat the thoracic spine when we're treating CCI. Vera, how come there are no 1B in your PICL treatment graph? Yeah, there certainly is a type 1B. It's just much more rare because it requires a lot of movement at the C0, C1 joint in extension. So 1B would be where there's an abnormal angle or too high a clivo-axial angle in extension. And that's got to be more than 180 degrees, which is something we rarely see. Now, it does happen, but it's much less common to happen. It's been advanced by Harry Winston. I was recently in a minor car accident. Bizarrely, my neck feels much better. Great, Harry. Is it possible that whatever was pushed out of position in the first accident could have been forced back to alignment? Yeah, that could be it. Obviously, that's the luck of the draw. And, you know, as my fighter pilot brother used to say, it's better to be lucky than good, meaning that if you got lucky and you're in a situation where you had something that was knocked out of place with the first accident, the second accident knocked it back in place, then, you know, do the sign of the cross and thank your lucky stars. Alex, wouldn't only getting one type of imaging possibly skew the results? For example, if they show a 2B, can't see a type 1. Yeah, well, not really the results, but I would say that it skews the data that I just showed you for sure. On the results, not really, because we can compensate for that through a hands-on exam. So I'll give you a good example of that we see all day, every day, right? Patient has type 2B CCI, which is C1, C2, moving sideways, and a DMX, AP, open mouth, lateral bending view. They don't really have the money or resources to get an upright reflection extension. Now, I could make them try to get an upright reflection extension, but that's pretty cruel because they've already qualified for PICL, and they may not be able to afford it if I make them go get a $2,000 cash upright flexion extension MRI. Having said that, during exam, I can tell based on the exam, for instance, if they've got type 1C skull sliding, which I can't really see on the DMX, but then I can add in those structures based on the exam. So usually the exam allows me to adjust for that. But you're right, in a perfect world, it would be great if I could get all the tests I wanted to, but regrettably in day-to-day practical medicine, trying to help people recover, we don't get that opportunity as much as we should. The presentation is hard to see, and the numbers are not visible because the screen resolution is set for a phone-like ratio like shorts. I should be broadcasting on both. If I'm not, then I apologize. But that could be if you're watching it on a phone or elsewhere. Maybe it could be if you're watching it in YouTube and not Facebook. So you might want to switch to the other one. But there is a new feature here that allows me to broadcast in both. So I'm broadcasting in both. So I'll have to look into whether or not maybe YouTube is preferentially taking the short aspect ratio because more people watch shorts on their phone. That could be, but maybe switch over to the Facebook channel where it should be seen in the other landscape format. Do you see sinus pressure and congestion in patients, especially when they lay down? They have a hard time breathing. Have they seen improvement after PICL? That's possible. That could be due to irritation of the fifth cranial nerve, or V2, the second branch. Having said that, obviously there are much more common causes of that, like a chronic sinus infection. But yes, that could be due to craniocervical instability as well. Could also be a spiky leaky syndrome too. I want to understand how CCI is affecting how I wake up. Most day I wake up in a full CCI episode. It can improve as day goes on. If you go to sleep during a flare-up, I wake up even worse. Yeah, so Taylor, some of the things to try that I've recommended to other patients in the past might be, for example, to use a cervical collar that's comfortable when you're sleeping, because that's not going to really weaken things very much like it would if you're using a cervical collar during the day, but it can help hold things in place. while you're sleeping. You obviously can also experiment with different pillows, etc., or different positions. But realize that CCI can become worse at night because the muscles that protect things go offline as you sleep. And then if you don't have the ligament protection, things can get out of place and you can get more symptoms. What are your thoughts on the all-point P&E procedure for CCI? Yeah, I just put this on the Reddit sub. I looked at it pretty extensively this morning. It's basically a physical therapy program with electroacupuncture. Do I think you should spend $2,500 on a physical therapy program that's P&E or pain neuroscience education based with acupuncture? Personally, I don't. I think that's kind of a waste of money. If you want to spend $2,500 on conservative care, which is what's being described, then you could do things like, if you were interested in the dry needling function, which is really what electroacupuncture is going to be, then you could try to find an experienced trigger point dry needling physical therapist who's experienced enough to do the suboccipitals. You could also work with Todd Ball, who has a lot of experience now in working on postural therapy in our CCI patients. You could find an IPA physical therapist near you. You could find an advanced upper cervical chiropractor. But if it were me, would I spend $2,500 on pain neuroscience education? I wouldn't. Pain neuroscience education, or P&E, just means that you're trying to talk the patient out of being in pain because their pain isn't real. And that's the general idea behind P&E. And then combining that with electroacupuncture isn't going to be some sort of advance. And then that website says other things like they're diagnosing CCI with ultrasound. Can't be done. So I don't know what it is they're doing with ultrasound to diagnose CCI, but my guess is they're treating a lot of patients that don't really have CCI. Maybe they just have some upper cervical issues, and that you can treat upper cervical issues with trigger point dry needling pretty easily and get some good results. So again, I wouldn't waste $2,500 on it. I'd spend my $2,500 elsewhere. Case end, if treatments to the neck improvements stall out, would you treat the pelvis since increased stability might help the neck? Sure, I think we'd have to look at that person individually to see what else is going on. But in our CCI patients, we're frequently treating the pelvis. Again, that's going to be the basis, support, or the foundation for the house. And then you've got the walls that come up, which is going to be the lumbar spine, the thoracic spine, and then the roof, which is going to be the neck. And we all know that if you've got a bad foundation with cracks in it, and one side of your house is 6 inches higher than the other, then you're going to see problems in the walls. You're going to see problems in the roof. So we do treat the pelvis in a lot of our CCI patients for that reason. I'm going to butcher your name, Sylvie. For patients from abroad, what kind of pictures do you need? Sorry for this, I already mentioned. I was diagnosed with CCI by Dr. Gillette. He did not want to do surgery on me. CCI diagnosis confirmed by Dr. Bettag. In Germany this year, did traction test, tether cord ruled out. I have an entire spectrum of POT, small fiber, MCAS. Yeah, so the biggest imaging we need is movement-based imaging. So that's going to be an upright MRI with flexion-extension. Going to be the most important things. You can also do a DMX, but if you don't have DMX in Germany, go on my YouTube channel and you can find a video there that will show a German just routine radiology center how to do a similar to DMX type view. And we've had a lot of German patients that have done that and have been very successful in getting us good enough images to get to a CCI diagnosis. Greg, if POTS is part of patient symptoms, would be beneficial to add hydrodissection of the vagus and stellate ganglion, especially with anxiety, fight or flight is pronounced. Yeah, well, we will routinely do hydrodissection of the vagus. We also get some of that into that stellate ganglion area as well, just because of the way that procedure is done. Now, stellate ganglion blocks are even more dangerous than PICL, meaning that they're higher risk than PICL because you're using anesthetic and you can actually create a code situation with a stellate ganglion block, which is not something we've ever seen with a PICL. So we don't want to do stellate ganglion blocks, but we do certainly treat that stellate ganglion with platelet growth factors, just like we're treating the vagus nerve in those patients. Cynthia, are you only collecting response data from patients that have completed their treatments and moved on? Not quite sure what the question means. We're collecting the response data from everybody. That's in the registry, but that requires patients to fill out fairly intense questionnaires. And then we have this as seen case series, which is only patients that are coming back into the office. So we have two different ways response data are being collected, one by a registry that tracks everyone 0 time point, 3 months, 6 months, 12 months, and annually. And then through the as seen case series, which is what I shared today. Tanya, dear Dr. Centeno, thank you very much for your time and the great explanations. Would you say that prolotherapy and CCI, if the alar ligament and transverse ligament are loose, would be a good bridge? No, really it's not going to be. So as I've always said, type 2B, which is going to be the first one you describe, alar ligament laxity, or type 2A, transverse ligament laxity, aren't going to really do well with prolotherapy, and I don't think you should waste your money. Now, if money isn't the issue, we certainly have patients that are not resource constrained, then give it a shot. But if you're trying to conserve resources, I would say you're wasting your money on posterior prolotherapy treatments in those two kinds of CCI because they're very unlikely to help. Jamie, what does the neck of patients with CCI, or why does the neck of patients with CCI get that jelly neck feeling or posterior neck muscles go offline? Yeah, Jamie, I think what you're describing is when the stabilizing muscles of the spine, including the neck, go offline, you can get this unstable feeling like it feels like jelly or it feels dangerous. And those muscles do go offline. We don't fully understand why they do, but they even atrophy. So how do you get them back? Well, you first have to fix what caused it, which is usually damaged joints, irritated nerves, the instability, and then you've got to slowly move up that functional ladder and get to strengthening to get them back. Hey guys, if you're with me here, we're at 53 minutes. I'm going to finish up the next 10 minutes or so, but please give me a like here, comment, subscribe, share, because that's how patients find this content. If you want to pay it forward in the CCI community, that's how you do it. Because as you might imagine, if you're watching this right now, there's probably 100 patients with similar symptoms who will never see it simply because the algorithm didn't show it to them. So do me a favor, give me a like, comment, share, subscribe to pay it forward so that other patients can find this information and so other patients can join us next time and get their questions answered. Tactical, hi Dr. Centeno, on what the patient can do side of things. What do you think are the biggest factors that lead to successful PICL result according to your current data? Yeah, I think we see, like I shared before, low functioning patients for that first procedure, if they respond, tend to knock the ball out of the park. They tend to go from can't function at all to being able to function. And that's wonderful to see. Now they've got the biggest amount of function to regain. So getting them back to doing higher level things can be difficult. Now, on the other end of that spectrum, we see patients that are high functioning, and those high functioning patients tend to get smaller individual gains, but they don't have as far to go, and they tend to be much more likely to get back to full function and doing, what would be considered crazy things for the bedbound patients. So running, weightlifting, etc. So that's generally how it goes. Vera, how do you inject the ALL-C3 down? I mean, from where, since it's below the mouth? Yeah, Vera, we've developed techniques to get it done through the PICL procedure. That took about 2 years for me to master, but I've mastered it now. So we can get pretty far down, almost always to 3/4, sometimes to 4/5, through a PICL without having to do a separate anterior procedure. Now, if it's going to be much lower than that, then that's going to have to be a separate anterior procedure. But because the ones we're concerned about are mostly 2, 3, and 3/4, because those are the ones that would cause upper cervical symptoms, we can get down that far during a PICL procedure, but it is an advanced part of a PICL procedure and one that took me about 2 years to master. Courtney, is 2.5 years after onset of symptoms a long time? In other words, does time frame make a difference for getting ePICL? No, Courtney, that's not a long time for us. Our average patient is probably about 3 to 4 years out. We do see patients that obviously are more acute, like 6 months out, and that can be a one and done treatment kind of patient. But 2.5 years is kind of right in the mix and a little bit on the light side when it comes to our average patient, as far as the number of years from when this started until when they get to us. When to use PRF or platelet-rich fibrin, I think what you mean, maybe. I'm hoping that's what you mean. Platelet-rich fibrin is not something we use. It's something that surgeons try to use because you can create a clot and place it. It tends to underperform PRP, so we don't use it for that reason. Tanya, hello again. Would you say, or better, is there an explanation for the fact that possibly the hormones or the symptoms are even stronger during hormonal phases such as menstruation? I think what you're asking is, at the end of the day, can your menstrual cycle and hormonal regulation during that menstrual cycle affect ligaments? And I think we know from other areas of medicine, like ACL tears in women's sports, that it can, that women are more likely to tear their ACL during certain parts of their menstrual cycle than not. So there does appear, now, whether or not the hormones are affecting the ligament integrity or whether or not the hormones are actually impacting neuromuscular protection, how hard the person is playing, we don't know any of that. But we do know that there is an impact there. And so I would say that there does appear to be a clear relationship between what's happening in the menstrual cycle and what's happening to ligaments. We don't really know much about how that impacts CCI, but we do know how it impacts other types of ligament issues like ACL tears in women's sports. Not sure if my comment was submitted earlier, but was curious whether bursa may be injected. Yes, I think what you're bringing up is during an ePICL procedure, if someone has an inflamed bursa, it's possible to get into that bursa. Now, let's break that down, right? What is a bursa? A bursa is a lubricating sac that exists in the body, usually where two bones would normally rub together. So in the case of C1, C2, there's a bursa between C1 and C2. There's also a bursa that comes around the side and can connect into the C1, C2 facet joint in some patients. So we will see patients that have inflamed bursas because there's instability there. And then it's possible to get into that bursa when we're doing a PICL procedure. Now we have strategies for injecting the ligament there versus the bursa. But the bursa can be entered into, and if it's entered into, you can get bone marrow concentrate into the C1, C2 facet if it connects. And that can cause more post-op discomfort in that C1, C2 facet if it gets bone marrow concentrate versus the usual PRP. Can braces negatively affect AO adjustments of C1, C2 and act on the PICL? If I were to have braces, do estrogen blockers for men negatively affect CCI somehow? First question, can braces getting braces impact CCI or PICL? Biggest issue there is really going to be head positioning. As you might imagine, during any dental procedure, the dentist is going to require the head to be in a certain position for an extended period of time in order to maximize their view to do what it is they're supposed to do. So that can certainly be a problem for CCI patients. I have a whole video on head or neck procedures in patients that have CCI. And then, do estrogen blockers for men negatively affect CCI somehow? Not that I know of. Caleb, have you seen any patients that complain of air hunger because of brainstem compression? That could be caused by brainstem compression. That could be caused by tightness in the SCM, putting pressure on the phrenic nerve, which lives right behind that SCM. That could be caused by problems in the rib cage, which many of our CCI patients have. But we certainly see CCI patients who report difficulty getting a deep breath. That tends to be less common than more common, but it's out there. Zach, how often do you see patients with dysphagia type symptoms, and what is the most typical cause? It depends on what you mean by dysphagia. If you mean actual problem swallowing, I think we talked about that one before. There's not a lot of distance between the esophagus where you swallow and the front of the spine. So if the spine is unstable, that can directly impact swallowing or eating. Now, at the same time, TMJ can do that, which is also frequent in CCI patients. Many of our CCI patients will also have problems with gut motility. So they will have GI problems due to vagus nerve irritation, for example, etc. Does wearing a soft collar while sleeping make this worse as far as making the neck reliant on the collar? Yeah, no, I think if you're going to wear a soft collar, that's the time to wear it if it helps you, because I think that'll have the least impact on the muscles, which is really what we're trying to do with the collar, right? We want to get benefits from the collar, but not cause atrophy. And wearing one at night is going to be the best possible thing you could do. Or if you wear it during the day, just wear it only every once in a while when you know things are going to get flared up, and spend 95% of your time out of the collar. Caleb, to add that O2 levels are normal, but it feels like you're constantly in need of a big breath. Yeah, Caleb, same thing that we talked about. All those different things can cause that sensation. Can you rank CCI types to causation of POTS, other autonomic symptoms? Not really, but I would say that C1C2 instability tends to be common with those, because C1C2 transverse processes are in places that can irritate the nerves that cause those autonomic problems. Afro, where can you get DMX in New York City, Long Island area? We have a whole list, so if you contact my office, they can send you the list of DMX spots. Marcia, I have type 1A and 1C. Why are my symptoms worsened by laying down? Well, if you're laying down on your back, since type 1A is a problem with low climaxaxial angle, if you're pushed into flexion, that can cause an issue. 1C is a skull sliding. So if you have your skull on a pillow and are lying in any direction, your skull can slide, and that would be why. Can clemastine be used pre and post PICL? I don't see on the list. Want to make sure. Clemastine. That's a new one on me, but and one I don't deal with in my practice, but let's look it up. Antihistamine. So not a big problem for use in, or when you're using it with a PICL procedure. No, not an issue. What usually causes temporary ringing in the ears? For example, if you lie down and turn your head, are nerves pinched? And what type of CCI is it usually? If you mean positional tinnitus, where the tinnitus is worse during certain positions, that's usually happening because of pressure on the internal jugular vein or other nerves. That could be common in type 2 CCIs. Is CCI often misdiagnosed as vestibular migraines? It is frequently misdiagnosed as vestibular migraine. In fact, a lot of our CCI patients have had migraine treatments, and either they work a little bit or they don't work, and they go down that migraine path, and then ultimately at some point figure out it's coming from their neck. So that's a problem, right? Neurologists are really not trained well in the neck and musculoskeletal problems, so they'll frequently take a patient down that migraine path when it's really from the neck. And obviously, if you're not using the right treatment and treating the right structure, you don't get good results. Vero is a Powers ratio of 1.1, mild, moderate, severe. We don't use a Powers ratio at all, Vero, for anything, primarily because it doesn't help us in getting to a CCI diagnosis or help a patient get better. Karen, hello, Dr. C. I'm contemplating coming out there from Florida, and I'm soon to be 72 years old. Do you mind telling me your comfort level at that age? Sure, Karen. We have patients in their 60s and 70s. We have a few in their 80s, but that's probably because obviously the number of people still functional enough to travel goes down by the time you get into the 80s. So not that concerning, but some of the things we would look for would be trying to make sure there aren't a lot of bone spurs that might impact our ability to get into the ligament areas we need to access during a PICL procedure. Thomas, patients who are dysautonomia dominant CCI patient respond very well to a vagus nerve hydro, but return to baseline about a month after the PICL with regards to tachycardia. I think that's a question. So again, so if you had a PICL, then the focus would be to treat that vagus nerve, but also to try to reduce the instability. So Thomas, the best thing to do would be look at around the 3 to 4 month mark as to what's going on with those vagus symptoms, because that would allow us to tell what are the impacts and effects of that PICL procedure. And I'm going to start wrapping it up here because I'm at 1 hour and 7 now. Tactical. Is fish oil on the do not take before procedure because of anti-inflammatory properties? Yeah, more the blood thinning properties. That's the biggest concern with fish oil, is we can see excessive bleeding during the procedure. And why is curcumin recommended? Because of damage. Let's see, I'm switching gears here. Curcumin is recommended because it's an anti-inflammatory that doesn't block inflammation in the same way as nonsteroidals. And then Thomas initially asked this one and then asked this one. Part 2 of the question is the reason behind that is because the patient still has yes, so that's what I was getting at, Thomas. And the nerve also could be damaged. Okay, guys. Questions are still streaming in, well attended, lots of questions. I'm getting past my 1 hour time here. So I'm going to start wrapping this up. If you enjoyed what you saw today, if you're thankful that a doctor is spending a Sunday morning with you answering your questions, which I have to say is a pretty rare thing. I don't know many doctors that do this. Please give me a like, share, comment, subscribe, because that's how people find this video. That's how you pay it forward to other CCI patients. And hopefully they'll be able to find this and realize that they can ask questions too on a Sunday morning. Going forward, we will be back to Sunday mornings. I don't think I'll be doing this next week, primarily because of Thanksgiving, but then we'll be right back on. And thanks for all the wonderful questions. Again, that's how we learn. You can't really underestimate the impact that a single question has on other patients, right? Sometimes it's validating. Sometimes they can say, oh God, I've got that. Or sometimes it's a question they wanted to ask, but they didn't have the courage to ask. And then they get the answer. So, you asking these questions can pay it forward and help other patients because they can see themselves and what's going on with them in that question, and they can get an answer. So thank you for participating today. I will, again, probably not be doing this next week on Sunday. I think I'll be traveling back from Atlanta. I'm going to Atlanta for the holidays to have my mother-in-law's memorial. and then but then we'll be right back on track after that. So have a wonderful week, and thank you so much for your time today. And I will see you in 2 weeks. Thank you.